Hello, this is Thomas Brueggeman, and my project is on those that are 65 and older with obesity-induced cardiovascular disease. In this presentation, I'll discuss the population of interest and the concern for obesity-induced cardiovascular disease. Adults age 65 and older have a large and still growing population. They are at risk for obesity and cardiovascular disease and have barriers to healthy living. The background is that in 2024 in the United States, there were 61 million people aged 65 and older. In the same year in Alabama, there were 932,000 people aged 65 and older. In Etowah County, there were 20,000 people. And in Gaston, Alabama in 2024, there were 10,100 people aged 65 and older. Increased cardiac workload occurs when excess body weight forces the heart to pump harder to circulate blood through a larger body mass. The obesity leads to plaque buildup in arteries, which further leads to atherosclerosis. The presence of excess adipose tissue increases vascular resistance, leading to higher blood pressure. Often, this leads to insulin resistance, which can increase the risk for type 2 diabetes and raise the likelihood of developing cardiovascular disease as well as sleep apnea. My issue of concern statistics are those that are obese are 25 to 50% more likely to have a heart attack. Those who are obese are 2 to 5 times more likely to have diabetes, 55% more likely to have a stroke, and heart disease kills 600,000 people annually in the U.S. every year. Alabama has a heart disease death rate of 247 per 100,000 people. In my review of literature, this particular journal discusses that in modern times obesity rates have skyrocketed, causing obesity-induced comorbidities and diseases. And this has led to new medications being developed to combat this, including GLP-1 receptor agonists. The GLP-1 receptor agonists have shown a significant benefit to those who are trying to lose weight. And this literature further demonstrates how obesity and cardiovascular disease are linked. In this journal, it shows that obesity is a significant risk factor for chronic diseases and uses a mathematical model to simulate how obesity spreads in populations and can be influenced through social interactions, peer pressure, and lifestyles. The simulation model further shows that with proper disease management, the population could overcome obesity and cardiovascular disease. This journal examines barriers and facilitators to weight loss in patients with cardiac disease. It uses a model of behavior known as the COMB, or Capability, Opportunity, Motivation, and Behavior Model. This study demonstrates how individuals who have experienced a cardiac event may be more motivated to take action and then control their own health. In this study, examined the dynamic between body weight, weight gain, weight loss, and cardiovascular disease. The study had shown that obesity, or a weight gain of 4% of body weight within a 12-month time frame, increased the chance of cardiovascular disease drastically. And in this paper, it showed that visceral fat presents a far greater risk than overall body weight. It also shows that the human body will recognize the benefits of exercise and reduced calorie intake by improved cardiac function, even if the individual does not see a significant weight loss. Overall, global rates of obesity has risen from 25 to 40% in the past 50 years and are responsible for approximately 2.8 million deaths annually. These rates are mainly attributed to diet and sedentary lifestyles. This increases the risk for comorbidities. Heart disease is the leading cause of death in the United States, with nearly 1 million deaths yearly and over $500 billion in healthcare costs. And while advances in diagnostic tests have improved, the early detection treatment of heart disease, maintaining a healthy weight, remains one of the most effective ways to reduce this risk. As we look at the GAP tool, it highlights the need for education and understanding and the consequences of not doing so. In the current state, the statistics reflect individuals who are overweight and have or are at risk for developing cardiovascular disease due to poor diet, lifestyle choices, or lack of awareness. In the desired state, we see individuals who are actively aware and engaging in behaviors that reduce their risk for obesity-induced cardiovascular disease. The gap is recognized in those who are overweight and at risk for cardiovascular disease and are not actively engaging in activities that reduce their chances of obesity or obesity-induced cardiovascular disease. The gap is due to a lack of knowledge, understanding, awareness, education, support, and possibly transportation. The method used to identify the gap was a review of local, state, and national data as it pertained to the ratio of overweight patients to those with heart disease. Looking into the SWOT tool, we analyze the population of interest. Their strength lies in community engagement as they participate in volunteer services and community initiatives. They also possess a large knowledge base, enhanced problem-solving skills, and offer a unique perspective gained from a life of experience. Weaknesses in this population may include chronic health conditions, a slower metabolism, which may lead to difficulty maintaining energy levels, vision and hearing impairments, as well as mobility and transportation issues. The opportunities available for this population include health programs such as wellness checkups and community screenings. There are nutrition and fitness initiatives. Community groups give support, recreation, education, motivation, and this population also has an extensive political group. Threats to this population include the potential for chronic disease, the risk for injury, the potential for compound injury due to falls. Technology competency deficit is often seen in this age group. And lastly, many in this age group have financial insecurity as income is often fixed and the ability to earn funds are diminished. As we look at the windshield survey, healthcare availability is abundant in Gadsden with 2 large hospitals and numerous doctor's offices. Public transportation is available and at low cost. The food environment is plentiful. Several locations offer pre-made meals, and there are food banks available. Gadsden City hosts 3 parks of varying sizes, all of which are well maintained and currently in use and popular for socialization and exercise. The overall environmental quality is pleasant, which helps those who want to use the park and engage for an outdoor activity such as walking. As we look at our informant interviews, in one interview with a registered nurse of 11 years' experience, she stated she was not surprised that heart disease was the leading cause of death in the United States and the most controllable risk factor for cardiovascular disease with physical activity. She feels that obesity is becoming an epidemic worldwide and that the deaths could be reduced and prevented mainly by education and physical activity. She also states that she has spoken to patients about obesity and activity levels with mixed results. In another interview with a community leader, care manager, who has been in the field for 11 years, states that he has a unique view on the circumstances based on his position and experience, and he feels that 70% of all obesity-induced cardiovascular disease is preventable. He also thinks that education and knowledge, starting with the youth, are paramount to the success of decreasing cardiovascular disease. For him, having a conversation with clients about weight loss and activity levels can be difficult, but is important and cannot be overstated. He is concerned that when it comes to obesity-induced cardiovascular disease, that noncompliance may be the biggest threat. Through the planning phase, I used Nola Pender's health promotion model as part of the framework. This model is applicable to the population of interest and is beneficial as it explains that people will engage in healthy behaviors as long as they perceive the benefits as outweighing any potential barriers and challenges. This in turn leads to the ultimate goal of promoting health through behavior. Through the planning phase, I was also able to use Albert Bandura's social learning theory. I believe that this is suitable for the group, as the theory is presented in a simple form, emphasizing that people learn from observing and doing what they see. They then model the imitation of what they have observed. By this process, they learn self-efficacy and the ability to complete specific actions for specific results. As we look at factors that influence obesity, one thing is the food environment, which can play a critical role for many, as often as high-calorie and processed foods, high-sugar drinks are easily accessible and more affordable. The physical environment may lend itself to a lack of activity or can discourage an individual from seeking physical activity. The socioeconomic, such as poverty, low education, and limited access to health care, can cause those in this bracket to limit themselves due to a lack of healthy meals and access to exercise. Individual factors such as genetics and poor metabolism increase one's risk for CV disease. Behavioral issues such as poor diet and low activity levels will also increase the chances of cardiovascular disease. Psychological problems such as stress, depression, emotional eating can lead to becoming overweight as well as cardiovascular disease. The lack of motivation and perceived barriers that individuals may have can be a deterrent to one's health. Agent factors such as having high percentage of adipose tissue or body fat may lead to insulin resistance, inflammation, or high cholesterol. Hypertension is often seen in those who are obese and can be caused by increased vascular resistance made worse by lack of activity. As we look at prevention, the most effective method for obesity-induced cardiovascular disease by means of prevention, primary prevention. You cannot have obesity-induced anything if you eliminate the obesity. Education on the effects of diet and physical activity is important. Remember that recommendation is a lifestyle change and not a short-term fix. From a secondary standpoint, we take measures to lose weight and then manage a healthy weight. Medical compliance is important, as keeping regular doctor's appointments and scheduled laboratory draws and regular screenings are beneficial. If you're participating in an activity that may be raising your risk factors, then steps are needed to reduce those activities. At the tertiary stage, it is important that the patient follow the doctor's recommendations for the management of the disease process. Pharmacological therapy will help patients manage the symptoms of cardiovascular disease and prevent its progression. As we look at our community diagnosis, we say that ineffective health maintenance is related to a lack of knowledge, education, and limited access to nutritional activity programs. Risk for ineffective coping as it relates to social support and limited engagement, and deficient community resources related to the lack of ability for those 65 and older, obesity management, and cardiovascular care. Our primary community diagnosis is ineffective health maintenance as related to a lack of knowledge, education, and limited access to nutritional activity programs, as evidenced by those who are obese are 25 to 50% more likely to have a heart attack, and those who are obese are 55% more likely to have a stroke. Using the roles of the Public Health Nurse to promote Healthy People 2030, I have developed a plan, educated the patients, challenged, advised, and informed the community. To check for competency, my goal was to have the participants be able to, at 90%, list 3 major risk factors of obesity-induced cardiovascular disease, describe 3 ways in which obesity and cardiovascular disease are linked, demonstrate the use of a pedometer or a pedometer app, analyze a food sample log, and evaluate the effectiveness and increased activity levels with proper diet by way of a dietary scale. Here, as we look at our budget, we had a modest budget, but it included some printed information, handouts, and a pedometer for demonstration purposes. Barriers to participation included limited interaction, accessibility challenges, low emotional engagement, insufficient participant numbers, a lack of interest. Additionally, age-related limitations, resistance to change, limited knowledge, literacy, language barriers, hearing difficulties, cultural differences, and transportation issues all could have the potential to reduce engagement. The education began with the information from the printed PowerPoint. This included information on ways in which obesity and cardiovascular disease are linked, then information on blood pressure, signs and symptoms of cardiovascular disease, a discussion on smart food swaps, a simple food diary was included, lifestyle changes and exercise information was provided. We did a demonstration on how to use a smartphone app or a dedicated pedometer to track steps, and the session concluded with a verbal test to assess for comprehension. The event was successful and everybody in attendance was able to pass the test. The project implementation at the cardiothoracic surgical office was presented individually, and it began with information from the printed PowerPoint, the information on ways in which obesity and cardiovascular disease are linked, then information on blood pressure, signs and symptoms of cardiovascular disease, smart food swap discussion was had, and we had a food diary as well. Lifestyle changes and exercise information was provided. We did a demonstration on the smartphone for step tracking or a dedicated pedometer, and the session was then concluded with a verbal test as well, and this was successful as everybody was able to pass the verbal test. Participants at the Senior Center demonstrated a higher level of engagement and enthusiasm than anticipated, and the attendees actively participated and appeared genuinely interested in the educational content. Most of them agreed to try to have a goal of having a healthier lifestyle. Participants in the cardiovascular office was presented with a different perspective, as many of them had genetic predispositions and advanced health conditions that may have limited their abilities. Evaluation of learning was successful by way of the verbal test, and all the participants was able to pass. The project evaluation was sustainable by the staff at both locations, and the project was successful by getting a commitment to obtain healthy goals and competencies. The education information can be used at any location. Others can build upon this by incorporating evolving technologies as they continue to improve. In conclusion, The project demonstrates the importance of focused education and intervention for adults aged 65 and older for obesity-related cardiovascular disease. Thank you very much.